This time around, we are very lucky and happy to have Professor Brian Goodman with us, and I'd like to take 1 or 2 minutes to introduce him. It's actually very difficult to introduce Professor Goodman because of a very extensive degree of studies and the involvement he has around the world. I believe I sent a short biography of him in the invitation email, and you have got some time to read it, and it's actually very rich. So Professor Goodman graduated in 1975 with a Bachelor of Science in Pharmacology from the King's College in London. And then he also obtained the Diploma in Economics and Business Studies in 1977 from the Sheffield University in the UK. And also in 2011, he got his PhD from the Open University in UK. And he has worked with numerous companies, governments, organizations, universities. I hope he is going to highlight some of them as in the course of his presentation as well. He has studied a lot of things in the area of pharmacy, specifically related to the use of medications. This includes developing new models to optimize the use of new medicines and valuing their methods to enhance the utilization of low-cost generics and biosimilars, and programs to enhance appropriate prescribing and dispensing of antimicrobials across all sectors, as well as medicine for non-communicable diseases, including the potential new quality indicators. In addition to that, he has actively researched in the extent and ways to address drug shortages, as well as documenting potential diseasement activities and the processes. These various activities have resulted in multiple publications across countries and continents, and chapters in books, as well as multiple conference abstracts in the presentation. The last time I checked today, Professor Goodman has about 361 research works on PubMed alone. I'm not sure of the exact number yet, but I believe it's close to that number as well. So with that, Prof. Goodman, welcome very much. The floor is yours.
Okay, thanks very much, Nelson. I will also say good morning, good afternoon, good evening, wherever you are. As Nelson said, what I'll try and do in the next 45 minutes or so is talk about the role of pharmacists to improve the management of both infectious and non-infectious diseases across Africa and across different sectors. So this is just based on the work that myself and others have published over the last few years. As Nelson has said, I started my research activities in 2006 at the age of 53. My son started a PhD at the same time, so he said, "Are you too old, Dad?" And I said, "No." I cut his allowance. No, I didn't. He got a self-funded PhD. But really started across Europe looking at the issue of generics, because that was a key issue across Europe at the time. We started to have the first generic proton pump inhibitors and the first generic statins around that time. And in some countries, we could get these as low as sort of 5% of the selling price. So every time a physician in Europe wrote to say torvastatin or rosuvastatin rather than simvastatin, then that cost the NHS about 5 to 10 times as much money. So really, we tried to see what could be undertaken across Europe to encourage the prescribing of multiple source medicines within a class to improve efficiency. And then we then research extended across Europe, looking at both new medicines as well as generics. And I co-founded a group of health authority people in 2008. And then that led into developing a Pan-African group in 2015. That grew out of the World Congress that we had in South Africa at 2014, where my boss at the time at the Karolinska worked heavily in Africa as well. And we're sitting around a table with colleagues across Africa. And we said, have you got a group across Africa that's researching similar issues around how to optimize the use of medicines? And they said no. So that's how we started our group. So since then, we published together some sort of over 450 papers across different countries. And there's just some of the African countries that I've worked with in the last few years. So this is a group that we started in 2015 at Port Elizabeth in January. We had our first conference in Botswana in 2015, funded by the helped by the Swedish organizations to help fund speakers coming in to talk about how to conduct drug utilization studies, etc. And we've been going strong since then. This is where we met in Botswana, sorry, in Port Elizabeth 2015. And this was our second conference in Botswana in 2016. As I say, we've been going strong since then, and we've now combined with ISPI Africa. So this was our recent ISPI African meeting, and all the abstracts and things like that are available on that website. So again, this has helped to really progress and move forward Pan-African research in key areas, both within countries and across countries. So that's what I would try and talk about over the next 40 minutes or so. Why it's important that we concentrate on Africa? I don't need me to tell you that the highest burden of both infectious and non-infectious diseases is in Sub-Saharan Africa, and by inference also the highest prevalence worldwide of people with both joint infectious, chronic infectious diseases and non-infectious diseases. So it really is a key area to investigate. And also, if you look at situations like HIV, then we see across Africa that the greatest proportion, or a high proportion of patients, and particularly you look at countries like Botswana, is in women rather than men. We just don't see that when we come to high income countries, where it's far more prevalent in men than in women. So again, the nature of the disease or the pharmacogenetics can be quite different in Africa versus some of the higher income countries. So that's why we really need to look at what is happening in Africa. We see also across Africa, as I said, we see growing prevalence of non-communicable diseases as our diets change, we become more urban in across Africa and things like that. So we do see a real rise in the use of non-communicable diseases. And that brings its own challenges moving forward. And now we see across Africa, certainly Southern Africa, more patients are now dying from cardiovascular disease and diabetes than they are from infectious diseases. So that's why we really need to concentrate on what we're doing across Africa and how we can improve the use of medicines. And that's where pharmacists come in, both in hospitals and in the community. So that's what I try and look at over the next sort of 30 minutes or so as we move forward. So what do we see? Nelson talked about shortages of medicines. I mean, we see that across different countries. So I've been part of European groups and global groups looking at how we can address issues of shortages from a global perspective. But if we look at Africa, then we do see shortages of medicines, particularly in primary healthcare, and that's an issue when we come to managing patients, say, with hypertension and diabetes. In South Africa, where I work, primary healthcare centres are supposed to have 90% available of essential medicines, but that's not always the case, and that can be problematic. So we're starting to look at how we can improve stock control generally in South Africa, feeding into how we can improve medicine supply across the country. So we started and we published on that going forward. This is one of the papers that we published early on, looking at contracts. So how can we improve the procurement process within hospitals such that hospitals don't run short of key medicines such as key antibiotics? How are suppliers performing? Are they being paid on time by the government? Because if not, then that could lead to supply issues, etc. So that's why we try to put in ongoing steps to try and put in, okay, how we can monitor medicine usage, things like that, using RX solutions, and how we can move forward, both in terms of better, if you like, better forecasting of the use of medicines and better supply and more consistent supply to hospitals such that they don't run out of key medicines. So that was a paper we published about a couple of years ago. So that's available, open access to you. This is a paper we published on medicine availability in rural primary healthcare centres in South Africa. And what we found is, not surprisingly, that they weren't always available. And that's a big issue going forward, because if they're not available here, then where do patients have difficulty procuring them from community pharmacists without a prescription, or obtaining them from community pharmacists. So what we're now doing in South Africa and what we see across Africa is to look at ways that we can improve the supply of medicines generally around ambulatory care. So we have what's called the Chronic Disease Management Program in South Africa, whereby patients can nominate where they pick up their medicines, rather than always going to a primary healthcare center, which may or may not have their medicines in supply. So we're looking at ways around this issue to try and improve the situation. So again, pharmacists and others are playing a key role in this aspect. What we're also starting to see in South Africa as well, and we see that growing across Africa, is pharmacists being proactive together with infectious disease clinicians to say, okay, if we haven't got a particular antibiotic at a particular time, then what can we substitute with? So start, rather than spending half a day trying to procure something which may or may not be successful, then what can we do in the interim to try and plug that gap? So that's what we started to do across South Africa, is to say, well, okay, if there's going to be supply issues, which there's bound to be from time to time, what therapeutic interchange messages, what therapeutic interchange medicines can we agree upon, such that if this does happen, then the patient's not compromised for any length of time. So that's what we started to do, and we see that growing across Africa and across other countries. So again, this is a paper that we published a couple of years ago, and this is available open access. The key issue across Africa, and is where hospital pharmacists can come in, is promotion. So what we see across a number of African countries is that sometimes the main source of information for physicians are pharmaceutical companies. And that's obviously a problem, particularly if that information is not particularly evidence-based. So obviously one way around that is to instigate pharmacy and therapeutic committees, or drug and therapeutic committees, depending which country you're in. However, what we did see across, say, for instance, Nigeria, is that at the time of our publication, only 50% of the hospitals, tertiary hospitals, are functioning DTCs. So by the time you get down to secondary hospitals and even primary hospitals, then obviously that's going to be far less. When these existed, chairpersons and secretaries, predominantly physicians, with pharmacists, who say playing a key role, particularly as secretaries. Hospital formularies were only available in a minority of the tertiary hospitals that we surveyed at this time. So heaven knows what happens when you get down to secondary care hospitals. So that's why we started to document this, to see what is a key role for hospital pharmacists across Africa, really to formulate and develop drug and therapeutic committees so that we can improve the use of medicines in hospital. We see greater activity in South Africa, and that's helped by the fact that there is now a national policy in South Africa to have functioning PTCs and have also quality targets for those PTCs. So I think that again is an example going forward of how we can help the use of medicines in hospitals across Africa. So these are just some of the papers that we published in Nigeria regarding promotional activities and also the impact then on antibiotic prescribing and on drug and therapeutic committees generally. If we look specifically at South Africa, then as I said, we see greater activity there than we see across a number of African countries. However, in the recent work that we did, yes, we do see PTC activities encouraging rational use of medicines, but really only a minority, only 60% were actually looking at drug utilization patterns within the hospitals, and did they comply with the agreed guidelines. And that's important going forward. I'll discuss it a bit later when we come on to antibiotics, because adherence to guidelines is seen as a critical quality indicator for hospitals, and that's where hospital pharmacists can come into play. We also see variable reporting adverse drug reactions. So again, that's a key role for both hospital and community pharmacists. So this is some of our, I won't go into it, but these are some of our publications on drug and therapeutic committees within hospitals in South Africa. Another thing that hospital pharmacists can do, and this is a paper we published a few years ago in Kenya, is really to document what is the utilization patterns of medicines within the hospital, both in terms of those that are vital, essential, and necessary, and those that are high, sort of low volume and high cost on one hand, and on the other hand, high volume and low cost. And then what is the, if you like, what are the typical patients that come to the hospital? So if you put all of that together, you can then develop what should be, if you like, areas that the hospital pharmacist should concentrate on, particularly any sort of high cost medicines that are seen as vital. Are they being appropriately used? And what about essential medicines at a high cost, or essential medicines or other medicines at a high cost that are not essential? What are we doing about those? So again, by doing this sort of activity, you can really get a good picture of use of medicines in hospitals, and are we utilizing them most appropriately given limited resources? So that's a key area for, again, for hospital pharmacists going forward, and that can lead into drug and therapeutic committees and again, quality improvement programs within hospitals. What I can say generally before coming on to infectious diseases and non-communicable diseases is obviously reporting adverse drug reactions is poor generally throughout all countries, particularly low and middle income countries. And we see the same in Africa. So I won't go into too much, but this is again a study that we did in South Africa, whereby pharmacists put into place education of physicians and how adverse reactions should be reported. And what we did see is that did have a positive impact going forward. And so again, this is another role for hospital pharmacists to improve adverse drug reactions. I said earlier, that's particularly important for Africa, particularly if you look at HIV, where again, we see a different pharmacogenetic profile there than would say in the United States. So that's why we do need these type of studies and this type of information in Africa going forward. But also say there's a greater prevalence of patients having both infectious diseases and non-communicable diseases combined. So like TB and diabetes, or HIV and diabetes, we see much greater prevalence of that in Africa than we do in other countries. So that's why very important that we have more knowledge about adverse drug reactions going forward. I won't go into it, but this is the studies that we have done generally about ADR reporting. This was another study in South Africa where, again, we talked about the importance or concerns with ADR reporting and how we can improve it. We've done the same in Ghana as well. This is more looking at again, at sort of more community-based or ambulatory care clinics, how we can improve on it. So we published on that recently as well. The last thing I'll say generally before I move on is how are medicines disposed of? And that's particularly important in Africa, because if we're consuming a large amount of antibiotics and most of them are self-purchased, and if we don't use them, we pour them down the sink or down and flush them down the toilet, then that's obviously a real concern, adding to antimicrobial resistance. So again, pharmacists and healthcare professionals can help to educate patients how to dispose of unwanted medicines. So again, that's what we recently published on, is how to move or how to improve on this situation. So that's very quickly some of the general activities we've done. What about anti-infectives? No surprise here that the first step really should be within hospitals is what are the utilization patterns? Generally across Africa, it's been quite poor, although we started to develop those, and I'll come on to that. Part of that's because it's been driven by really a lack of activity. The WHO have only just started to really
Sorry, can we mute our microphone if you're not talking, so that we can hear Professor Godman?
Okay, great. Okay, so one of the things that we started to do across Africa was to take on board what we have seen with the global PPS studies. So we see some publications on that, which include a few African countries, and also the European ones, to start to develop our own forms for Africa. So that started in Botswana. why we did that is because in Africa, we see a greater proportion of patients with HIV, TB, malaria, and malnutrition than we see in a number of other countries. So we wanted to know what impact that was made. More recently now, we've seen the global one take on board. So I think that will become the if you like, the standard for the future. But this is what we started to do across Africa. And in South Africa, we actually developed an app to help us with improved utilization. So because these studies can be quite time consuming. So we developed an app to help us to collect the data, rapidly collect it, and also rapidly analyze it to help improve the situation. Another area particularly is surgical site infections. I'll come on to that because what we see routinely across Africa is that instead of just having one shot, say 30 to 60 minutes before an operation, we see in some countries that the antibiotics are carried on for 5-6 days afterwards, which is obviously far too long and leads to AMR. And part of that's because they're concerns about the cleanliness of the theatre, cleanliness of the wards, things like that. But that's just overproduction of antibiotics that just increases AMR and costs without actually really helping the situation. And what we started to look at more of recently is obviously the WHO have come up with their AWARE list. So that's the access, watch, and reserve antibiotics. So we started to build those into quality indicators going forward, and I'll come on to that. But obviously a key area as well across hospitals, which is where hospital pharmacists can come into play, is the Antimicrobial Stewardship Program. So I'll say a little bit about that going forward as well. So this is the first study in Botswana using our forms adapted from the global and ECDC PPS studies. And what we did see was a high usage of antibiotics in hospitals was helped by a higher rate of HIV. So 40% of all inpatients across Botswana at the time had HIV. So that's why we wanted to include that in our co-founders, if you like, confounders, because we don't see that across other countries, other continents, sorry. And the same with TB. So that's why, again, we wanted to include that. Generally, what we do see across most of the African countries, quite high use of antibiotics for inpatients, less so when we come to South Africa. That might be helped in South Africa by the fact that we got much more active antimicrobial stewardship programs there than we do in a number of the other countries. So this is just what we've done in South Africa. So this is the development of this app, if you like. And this is some of the work we recently published on quality indicators, really looking at the AWARE program or the AWARE classification to help to develop quality indicators. And this is just our work that we published in 2021. Again, trying to look and see, okay, in the medical ward, surgical ward, ICU, what sort of antibiotics were being prescribed and how did they stack up on the AWARE classification. Because what we should be seeing across hospitals where we can is increased use of access ones, which should always be there, but much more critical on watch and reserve ones. Reserves ones are really should be last resort, because if we overuse them, then we get resistance to these really critical antibiotics. So we should look to reserve those on the reserve list as much as we can. What we also seen in other, so this is in Nigeria, where again we saw quite high use of antibiotics, and also we recently published looking at other LNCs, including in this case Iraq. So what we see across Africa is generally overuse of antibiotics in hospitals, whether it's surgical site infections, whether it's generally. So we should look to see how we can improve on the situation, because with few antibiotics new ones being launched, we need to preserve those that we have as much as possible. One of the problems that we have is in quite a lot of the African countries, there's very few use of sensitivity analysis. So generally, most prescribing is empiric. Quite often the doctors don't write what the indication is in the notes. They don't write a stop date or review date. So all of that really adds to problems of overuse. And as I say, in one of our Nigerian hospitals, I say only 35% of tertiary ones had a formal structure for stewardship programs. So I think that that's an area going forward where I think it's critical that hospital pharmacists can get involved with, to make sure that when a patient is prescribed an antibiotic, then the doctors write in the notes what it's for as far as possible, what the start date, review date, particularly moving from IV to oral, things like that, so that we can really improve the use of these drugs. Also, what are the sensitivity patterns in the hospitals to actually ensure that if those antibiotics are prescribed empirically, then we make sure that that the doctors are aware of what the sensitivity patterns are within the hospital. So I think all of that is a key role for hospital pharmacists going forward across Africa. This was another study in Zambia that we recently published. Again, there was limited knowledge about antimicrobial stewardship programs, things like that. So again, that's a training area for hospital pharmacists going forward. So I think, again, that we need, if we don't have stewardship programs in place within hospitals, we need to instigate that, because that could help drive appropriate use of antibiotics in the future for given situations. It was better that we saw in this study in Ghana, that at least it was more appropriate prescribing ceftriaxone. What we do see, as I say, what is a key indicator going forward is what is the adherence to guidelines. So again, what we can develop in hospitals is guidelines for specific situations with the key stakeholder groups, and then assess adherence to the guidelines, and then use that as a quality target going forward. Signs of that in Namibia, and also encouraging signs of that in South Africa. Although there were concerns with extended use of prophylaxis in South Africa, which I'll come on. So what we see driving forward is for hospital pharmacists not only to get involved in stewardship programs, but also to look and work with key stakeholders around what are the guidelines, can we monitor adherence to the guidelines, and use that as a quality target going forward. So these are just some of the papers that we published recently. And this is in South Africa, where again, hospital pharmacists have played a key role in the development of antimicrobial stewardship programs. So this is why I say there's a good role for you going forward to help in hospitals across Africa where this is needed. And this is just again to look and say, okay, South Africa do have a national strategy for antimicrobial stewardship programs. What's happening? Again, hospital pharmacists can look at that and say, okay, are we complying with the framework? What are we doing about it? If not, we can use that to drive towards the future. So again, we recently published on that. Lastly, as I say in this section, if you look at surgical site infections, as I said earlier, and there are real concerns across Africa that patients are getting prophylaxis for far too long. So again, this is a key area to look at, which we published on. And this was a paper generally looking at not only Africa, but across lower middle income countries to see what is happening, and then what programs can be put into place to improve the situation. And we discussed some of the programs that have been effective. So again, that can be a guide going forward. So that was very quickly for hospital care. I'll look now very quickly at ambulatory care, because again, we see the same concerns in ambulatory care we saw in hospital care. That's compounded in ambulatory care because we see a lot of self-purchasing of antibiotics. So that's obviously an issue that we need going forward, although we do see some examples where we have been successful. And that's in Kenya and Namibia, so I'll come on to that towards the end. What we've been doing a lot of recently, and we build on, is to say, well, if you look at the WHO INRO criteria, they have us, I think, less than 30% of patients should get an antibiotic. That tells you nothing about what is the quality of prescribing. So the work we started to do in Namibia is to say a better quality target is actually adherence to guidelines. So this is the work we put into place to say, actually, if you look at the WHO INRO criteria, that tells you nothing about the quality of prescribing. What you should be looking at is to say, okay, what do the guidelines say, and what's adherence to those guidelines? So this is a paper that we wrote in 2019. We're looking now to build on that across Africa, because we're working with St. George's Group, who developed the AWARE classification and the AWARE guidance, to really get a better handle across Africa as to what is the prescribing patterns in ambulatory care for infectious diseases, and use those then to help to set pertinent new quality targets based on the AWARE guidance. So that's work we just started on across Africa. This is compliance to the standard treatment guidelines. Again, just showing that now this is built into the programs in Namibia. We do see greater adherence to guidelines and therefore greater adherence to the quality of care. And part of that's helped by the fact that the guidelines are up to date, they're easy to use, things like that. So if you do get involved in guideline production, make sure that they're easy to use and easily accessible. It's no good having a big book, 200 pages, where you've got to leaf through and find the actual disease and then work down to see what is the guidance. They should be easy to use going forward, and that will help to enhance the use. So this is the paper that we published again about a couple of years ago. Because we do see that compliance with guidelines can be a problem. So this is the work that we did in South Africa a few years ago, looking at sexually transmitted diseases, where we saw that there weren't always adherence to the guidance. And this is the same that we saw recently in Ghana in ambulatory care. So this contrasted with the findings that we found for ceftriaxone and in hospitals. So this again is an area that community pharmacists or others working in primary healthcare centres can look at to say, well, okay, are we adhering to agreed guidelines? If not, then how can we improve on the situation to improve future antibiotic use? Regarding self-purchasing, that is a big problem. However, in Namibia, because the government's quite strict and monitors the use, and also the pharmacists are sort of taught in the schools that they shouldn't dispense without an antibiotic. Coincidentally, we actually went to patients living in informal settlements. So this is a group that are most likely to self-purchase medicines. And we were interested to know, okay, if you've got acute respiratory infections, how were these treated? And we were pleasantly surprised actually, that there was no self-purchasing of antibiotics. They did use other treatments, if you like, but certainly no self-purchasing antibiotics within community pharmacies. So that helped us a lot and provided us with opportunities going forward, that if you have trained pharmacists within community pharmacists and they're aware of the legislation that you shouldn't dispense an antibiotic without a prescription, then that does work in practice. So that was in Namibia, and we've seen the same in Kenya as well, where there are trained community pharmacists. And we follow that up by looking at what was happening with COVID, because there's obviously been an overuse of antibiotics for COVID. And again, we saw in both Kenya and in Namibia that if you have trained community pharmacists, they're aware of the situation, they're aware that these are viral infections where antibiotics will do no good, then they can persuade the patients that they don't need an antibiotic, they need more of something like an aspirin or paracetamol or something like that to help them through, plus potentially something for their cough. Because we do see, let's just say, a real issue going across Africa. Some work we did in Zambia found that 100% of the pharmacists dispensed antibiotics without a prescription some of the time. So it's a big issue going across Africa, and it's a key driver of inappropriate use and AMR. So that's why we started to look at this problem, to start put potential solutions into place. And now, as part of national action plans, really started to build on that. So what I sent to Nelson afterwards, just yesterday or the day before, we actually documented what was happening with AMR across Africa with the national action plans. What was happening in each of about 15 African countries, what were the challenges and things like that. So we just published on that. So we'll send that. That again can help guide what should happen across Africa going forward. That built on the study we did mainly across Africa and other low-income countries to say, what are they doing about managing URTIs? A key area, lastly, as we go forward, is misinformation. And you don't need me to tell you that around COVID-19, there was a huge amount of misinformation that started with people thinking that hydroxychloroquine would be the answer. And that was fueled obviously by Trump and what he was saying. More recently, certainly in Southern Africa, ivermectin was put forward as an antiparasitic for helping. And again, it had no benefit whatsoever. But these were all fueled by social media with little input from healthcare professionals. And what we did see in this paper in South Africa was a spike in both ivermectin use and hydrochloroquine use. But again, this is where community pharmacists can come into play to help to guide the patients around what is appropriate or not. And also in the case of COVID, then social distancing, PPE, things like that, and also vaccines. Because what we do see across Africa is quite a lot of vaccine hesitancy. Yes, there was some slow rollout of vaccines across Africa. That wasn't helped with all the hiatus around the Oxford AstraZeneca vaccine. I was talking to Nelson beforehand. It really annoyed me that this was a vaccine that was developed with the aid of grants from the government. AstraZeneca were the only company that agreed to make it at cost. Easily transportable, like other vaccines, didn't need freezing like we saw from, say, the Pfizer one. But there's been a lot of misinformation around it. And I think in South Africa, I think it was actually taken off the market for a while. I don't know what the situation is more recently. But we do see, and therefore all this misinformation has resulted in high hesitancy rates in a number of African countries. So we need, again, community pharmacists to help to convey these are effective and safe, and also help with the administration so we can get rates up to where they should be. There's also can be concerns around HPV vaccines. So this is a paper that will be published in about a couple of weeks because we're just going through the proofs now. So this was the work we did with pharmacists, etc., and others in Kenya. These were patients attending the medical clinic in the leading hospital there. So we asked them about the parents about the sort of attitudes, both the male and the female, using that, so both husband and wife, using that information to guide future activities, because there are concerns with HPV vaccine. One of the misinformation is that these are being peddled by the high income countries to keep birth rates low in Africa, which is just clearly not the case. So very lastly, coming on to non-communicable diseases. As I said right at the start, we see real issues with the management of hypertension across Africa. We see growing prevalence rates. I mean, this is just some work in Namibia, where up to 45% of the adults have hypertension. So, I mean, this is a big issue across Africa that's not being helped by increasing urbanization, increasing salt and fat in the diets, particularly the fat and sugar, things like that. All these are causing a problem. Now, we can help these patients certainly by adhering to medicines, by looking and treating them with appropriate medicines. But a key issue obviously is around, well, are these medicines available? Are they affordable? What about issues such as adherence? And what about patients' beliefs, particularly do they actually comply with lifestyle and things like that? Do they exercise more? Do they change their diets? Things like that. And all these can be put into place, particularly with the help of community pharmacists or pharmacists working in primary healthcare centers. And we do see programs across Africa to try and improve on the situation. We've done some diary studies, we've done other studies in the different African countries to try and improve the situation. And type 2 diabetes is also a growing problem across Africa. So again, the similar sort of interventions can be put into place. Do they get appropriate medicines? Are they complying with the medicines and with all the medicines they take? What about, again, about diet, exercise, things like that? And because adherence, as I said earlier, across all these non-communicable diseases is a big, big issue, not only in Africa, but across countries. And what we tried to do across different African countries is to say, well, okay, what are current adherence rates and what's the issue? And what we saw across NUI was having sort of, if you like, a support system in place, help with making sure that the patients attended the follow-up visits, and they also helped to enhance adherence. And what we did see in South Africa was that having pharmacy-led interventions, particularly around diaries and things like that, helped to improve adherence rates and helped to help with control some of the high blood pressure. So these are just some of the results that we saw. Again, similarly across Africa, we see a appreciable increase in type 2 diabetes, which is obviously the main one we see across Africa. And so what we're beginning to see is African countries starting to put into place programs to help address that. And these, again, looking around issues of detection, looking around how can we help with issues of lifestyle, how can improve, if you like, how access to medicines and actually taking the medicine. And pharmacists, as I said earlier, can have a key role in helping with that situation. And that was the paper we published a couple of years ago, again, across Africa, trying to look and see what were the rates of particularly type 2 diabetes, what were current management approaches, what could be done in the future to improve the care of these patients. And this was because what we did see when we actually started to look at these issues is that there were actually concerns with knowledge about diabetes. And this is okay in South Africa, but this could be across Africa, where patients didn't really know why they were getting their medicines, what they were being used for, things like that. So if they don't know that, then they're not actually going to comply with their medicine. So again, that was a wake-up call for us to say, okay, what can we do, particularly with pharmacists working in healthcare centres or generally, to improve on the situation. Again, what we saw in Botswana in hospitals, and this was in a tertiary hospital, that there were concerns with statin prescribing. Now, for patients with type 2 diabetes, that almost should be mandatory following the heart protection study. But again, most patients didn't have a statin being prescribed. So again, hospital pharmacists come into play, working with the clinicians to make sure that the patients are getting the appropriate medicine, particularly for the prevention of coronary vascular disease, which is a key issue, obviously, among patients with type 2 diabetes. And that was a paper that we published on knowledge of type 2 diabetes amongst patients in South Africa. This was lastly a recent paper that we published on tramadol. I won't go into it, but again, we can see, okay, this is an increasing area of concern across Africa. What are the standard treatment guidelines saying about tramadol use? Are we actually adhering to them, things like that? And what can we do about it? So that's what we published a couple of years ago on that. I just won't go into it, but this is, again, the other activities the hospital pharmacists can do, particularly around non-communicable diseases, to improve on the situation. So in conclusion then, I hope I've shown you really over the last 30 minutes or so that there is considerable inappropriate use of medicines across Sub-Saharan Africa, whether they are for infectious diseases such as antibiotics or for non-communicable diseases such as those for hypertension and diabetes. And I think pharmacists can play a key role in hospitals, particularly around do we have functioning PTCs? As we saw in Nigeria, even in tertiary hospitals, this was a rarish event. So do we have functioning PTCs? How do they work? Can we build, what sort of indicators are in place? Can we build on what we see in South Africa? And how can we use that going forward? What about adverse drug reaction reporting? Again, that is pretty dire in most African countries. So what can we do to improve on that situation? And what about issues such as medicine reconciliation? Again, we've published on that as ways forward, but I didn't actually include it because of time. But again, hospital pharmacists can get involved in that. And also get involved in the community, improving the care of patients with infectious diseases. What about, I mean, this is to reduce self-purchasing of antibiotics. This is about addressing misinformation, particularly around COVID and other infectious diseases. And what about ADR reporting? And again, can also play a key role when we come to the management of non-communicable diseases, particularly hypertension and diabetes, type 2 diabetes, which are both of which are rising across Africa. And I said earlier, now killing more people. So the complications of these than infectious diseases. And also, therefore, we do need ongoing research across Africa. What is the current situation in each of the countries? What's happening? What programs can we put into place? Let's monitor the effectiveness of those programs to help to then to say what further interventions do we need to improve future care. So that's it. That's all I've got to say. Thanks very much for listening and opening to questions.
Okay, thank you very much, Brian, for a wonderful presentation. It has been really nice to see all these findings and a lot of insights from your findings about communicable disease and non-communicable disease across Africa over years. And I hope the audience will agree with me that it has been a very informative talk this afternoon. So members of the symposium, the presentation is now open for questions and discussion. And you can do so in two ways. You can directly type your question in the chat box and we'll be happy to read it for you. And also you can choose to raise your hand using the raise hand function, then I will pick you up to ask your question directly. If that's not possible on your side, you can also switch on your microphone and ask your question directly. So I already see Zainaba Slada, I think you want to ask your question. Welcome. It seems not to be the case. Anyone, you have a question, please, you can proceed. I hope we are still digesting from the... Okay, so maybe Brian, to start with, you mentioned earlier about the issue of generics and how you tackled it in the UK and other countries across Europe. I know the problem of generics prescription is still a challenge to a number of African countries. And do you believe that the factors which were then the factors associated with this issue in the UK are similar to those which are happening across Africa?
Oh, thank you, Nelson. That's good. Remind me, I'll send you a paper on generics. I think one of the key issues for generics across Africa is the quality of the generics, because we do see falsified medicines and things like that. So I think the problem is, and I know the WHO are trying now to drive, and I think the African Union to drive initiatives to reduce the rate of falsified medicine. Because when we do that, then, and we got confidence in generics, then we'll increase the utilization of generics. So I think that's an issue that we don't see in Europe, that we do have seen across some of the African countries, is if the physicians don't trust the generics, then it's difficult to get them to increase the rate of generic prescribing. So I think the regulatory authorities have a role then in to reduce the rate of falsified medicines. They can follow the WHO initiative, etc., so that we can really use that to enhance the use of generics.
Okay, thank you. I see a question in the chat from Edwin Lelinka, and he's asking, management of type 2 diabetes mellitus in Africa has increased. How is it being managed? I hope you touched about this. Maybe you can expand a little bit for him.
I think it's mainly around the use of initially medicines such as metformin. So I think we need that first, and then is that readily available? What about the use of sulfonylureas? What about the use of some of the gliptins and glinides, although they're more reserved because of their cost implications? I think firstly, it's medicines such as metformin readily available. What about issues around lifestyle, diet, things like that? I think all those can go into place to improve, because we do know that if we get the patients to exercise more, adjust their diet, then naturally we can reverse type 2 diabetes. So I think we've got a major on that. And if we do prescribe oral anti-diabetic agents, make sure that they comply with them. The same with antihypertensive, because compliance can be really quite poor. And lastly, make sure these medicines are available in the healthcare clinic. Because if patients come to the clinic and they're not available, then they've got to go to a community pharmacist, which they may or may not have to co-pay for. So I think in some countries, if the drugs are available in the healthcare center, quite often they're free of charge, but if they have to go to a community pharmacist, they might have to pay for them. So again, making sure that these medicines are available, they know how to take them, make them as low cost as possible or free of charge preferentially, then that helps with adherence and control of their diseases.
Okay, thank you. I see a hand from Barbara Katusime. Katusime, you're welcome.
Oh, thank you. Thank you very much for that informative and wonderful presentation. My question is regarding polypharmacy in terms of the research you've done, just shed some more light in terms of how is it in the different countries. I'm currently working in the UK, but also have research in Uganda. So I would like to know if you have some information about that, because we have patients that have of course, on 20 medicines plus, but also treatment burden is also a big issue. So I don't know, in the research you've done, have you come across that? Thank you. Yeah.
Thank you. No, that's a very good question. I haven't looked at polypharmacy per se. I think most of it is around the appropriateness of the medicines being prescribed, and are the patients aware of that appropriateness? I said earlier that we see patients, say, with joint long-term communicable diseases such as HIV, chronic TB, etc., as well as non-communicable diseases like diabetes or hypertension or mental health illness. So I think we're likely to see many more combinations of that in Africa than we are saying in the UK. I think that's where the hospital or the community pharmacists can come into play to really make sure the patients are aware of the medicines they take, why are they taking them, and to make sure that they're as appropriate as possible. And so if the patient is, say, continues to be hypertensive, it's no good adding a third or fourth antihypertensive if they're not actually taking the first one. So again, is making sure that they're aware of why they need to take them. Also, what we see in South Africa with the CCMD program is that making sure that perhaps we can deliver or get the patients can pick up the medicines at the place that's most convenient for them. So we see in Africa, obviously, a lot of informal workers, and if they don't work during the day, they don't get paid. So that makes it very difficult for them to go to a primary healthcare center to get their medicines. So if they can say, okay, they can pick them up from, say, 7 o'clock or 8 o'clock at this store, this convenient pharmacy store or wherever, then again, they're more likely to take their medicines. I think, again, so it's making sure, are all the medicines appropriate? Do they know why they're taking them? Do they know what the regimens are? And making sure that we actually make them as conveniently available as possible for the patient. I know we talk a lot about polypharmacy, but to me, it's much more about appropriateness.
Right.
Because if a patient is a type 2 diabetic, then they're going to be on 1 or 2 oral antibiotics. They're going to be on 1 or 2 antihypertensives. They're going to be on a statin or whatever. They're going to be on aspirin. So very quickly, and if they've got HIV as well, then they're up to lots of medicine. So we need to make sure, I think to me, the word appropriateness is better than the word polypharmacy.
Okay, excellent. Thank you so much for that response. I think my final question was regarding, you've mentioned about, pharmacists being able to explain why medicines are being used. I think we've done a study in Uganda, so looking at access to medicine information, particularly in Kampala. So we found in terms of, of course, health literacy is a big issue. So we don't know how we can help that, because even in Kampala, urban central, we have issues around literacy and understanding. So I don't know if how we could help with that. Do you have any ideas? Sorry, Brian, that's my final question.
I've written twice down, actually, 2 things. One is diagrams. And I know there's been work done in the States, and I think my colleague in South Africa has been doing some work. So simple diagrams explaining to the patient. So if they don't understand fully the written word, then again, you can use diagrams and things like that perhaps to help them to move forward. So I think that. And then Do they have family members, etc.? So what about using do they have family members who are more literate to help them with a diary or something that they can then document what they're doing, etc.? So I think greater use of diagrams, and also there are family members who are more literate that can help them with diaries, etc., to move forward. So I think they're two potential ways forward.
Oh, thank you. Yeah, I think yeah, certainly that can help with the diagrams and the relatives. Certainly we'll have to look into that for our implementation studies. Thank you very much for your thank you.
Thanks, Barbara, for nice questions as well from you. I have more questions on my chat box here, and they're saying, Teopistaloto is asking, antimicrobial stewardship in Africa are minimally conducted. What's your advice on that? Maybe I add on that question, like you mentioned the success story of the antimicrobial stewardship in South Africa, particularly. Would you like to share with us maybe what were the factors toward this success we observe in South Africa as far as antimicrobial stewardship programs are concerned?
Okay, thank you. Good question. I've written down the name of a paper that's recently been written that's actually shown that antimicrobial stewardship is growing across Africa. So I think myth at one stage is it wasn't happening, but it is. Secondly, I think this is why I'm going to send you the National Action Plan paper, because within it, every country in Africa should have a National Action Plan for AMR. And a critical part in that is actually to know current utilization patterns. So once you know utilization patterns, then you can know areas for quality improvement, and that's where stewardship comes on board. I think Africa is further ahead just because they've had active people to really monitor and get to know what utilization patterns are, with Mark Mendelsohn probably being a key and Adrian Brink. So they've had key people within the government or allied to the government that have really pushed forward the appropriate use of antimicrobials. But now, yeah, WHO, as you know, in 2015 said that every country should have a national action plan. What we know is it's variable across Africa. We've got obviously issues about implementation, we've got issues of finances. But what we do have is every country is evolving. Some have actually launched, some are about to launch. And when they say critical is to know what your utilization patterns are. So once you've got that written into place, then your stewardship should build on that, because what you're saying is, okay, our utilization patterns can tell us what areas for improvement, and therefore we can focus on those. So what are the key areas first? So in hospitals are going to be things like surgical site infections. I bet in every hospital in Africa, there are patients that are given prolonged prophylaxis for a start. Secondly, what about, do we know what our resistance patterns are within each hospital? I bet we don't know in every hospital, and they can then lead into guidelines. And thirdly, what about simple things like, do the doctors write what the diagnosis is? Do they write a start and stop date? Do they write a review date? Do they quickly move from IV to oral? I bet they don't do all of those. So again, they're key areas to look at for stewardship. So the first thing is, do we have a national action plan in place? And the paper will show where we are at different countries. If we do, then utilization is a key area in both hospitals and ambulatory care. In hospitals, then can we use that to drive future stewardship programs?
Okay, thank you very much. I have a question from Christopher Oswald Migoha, and is asking, have you done any studies on to establish impact of medicine policies in compliance or adherence of using medicines?
Yes, we have, and we've put some of those on place, and I sent some more over. So what we've done is to say, okay, what, and the National Action Plan is a good example of that. So what are we trying to improve? So what is the current utilization patterns? How does that lead to, what are the quality improvement targets? Put the intervention into place and then monitor how successful that is. So we've got a number of examples across different countries on that. So I'll send over some papers on that, because that can help to guide what's going on. Somebody said, can we share the slides? Absolutely. They're available. I sent them to Nelson. So yes.
Okay.
So have a look at some of those papers, because they helped also to answer that question.
Okay, thanks. Lawrence Eokesha is asking, how can one join Muria?
All right. Well, there's no. Well, look, what I would do is go to the ISPI Africa website. So number one, and that will be helping to move forward, because the great thing about ISPI, I think you can join for, I think, $50 or $75 a year for somebody from Africa, because that helps with the organization. They're the ones now running the annual meetings. So I think that's good. Just send me an email as well, as to, you can see what countries we're working in. So have a look at those, and then we can put you in contact with people who are working in that country. We've basically been an informal group. We've had, as I said, we had a little bit of money from Sweden early on so that we can pay for a few people to come and talk to us. But we've basically been a non-funded group of enthusiasts. So that's the best way to look at that. So ISPI have now taken on board as a more formal organization looking at pharmacoepidemiology, which I'm very pleased at, because I had to run the first 4 conferences, which was quite a task on top of what I'm all doing. So now they've taken that responsibility over. So let's say it is an informal group. Look to join ISPI Africa if you can, and then email me, and we can put you in touch with those working in the different countries, because we want to encourage more people to research and to improve medicine use throughout Africa.
Okay, thanks, Brian. Dr. Betty Maganda is asking, do you think it's a good idea for community pharmacies in Africa to start doing simple screening like blood sugar monitoring, which can be helpful in improving adherence to treatment?
I think absolutely. I think firstly, diagnosis, because we know an awful lot of patients with type 2 diabetes and hypertension are just not being picked up across Africa. So to me, then yes, I think as we move forward with improved management of non-communicable diseases, we need to identify more people who are at risk of future complications. So absolutely, yes.
Okay, cool. Also a question from Amasha Kigosi. Thanks for the presentation. Many of the African countries are still developing countries, and the access to healthcare is still the challenge. So in your opinion, how can the pharmacists be involved in the management of both infectious and non-infectious diseases?
I think in infectious diseases, certainly with the common ones like upper respiratory tract, absolutely. And they can guide the patient to have a paracetamol or cough medicine rather than an antibiotic. So I think they can be critically involved there. I think for non-communicable diseases, we talked about diagnosis. So maybe that's a role there. And also when the patients come and want their medicines, they can get critically involved in saying, well, do you know what they're for? Because that's what we saw with the type 2 diabetes, didn't really know what they're for. Do they know what they're for? Do they know what the dosing regimen is? And can help them in that way. So I think really improves their role to help them move forward. One of the papers I showed on Namibia in COVID was the Namibian pharmacists were quite proactive. So they put into place sort of early on, had they got enough PPE? What about talking to the patients about social distancing, things like that. So again, pharmacists can help with that type of pandemic, is to say, well, okay, what you should be doing, dispel the myths, let's say, around hydroxychloroquine and ivermectin that we saw growing up, and really help there. So I think there's a key role with them, both infectious and non-infectious diseases.
Okay, thanks. Members, if you still have a question, you can continue to type it in the chat box or raise your hand and ask it directly, as we still have some minutes before our end time. Brian, you shared about the success in Namibia of not having self-purchasing of antibiotics completely. To me, who is coming from another corner of Africa, this sounds like a miracle. Now, like maybe you can expand a little bit on what were the driving factors toward this success, because I believe in other countries we also have laws and regulations, but the business forces are sometimes stronger than these guidelines and regulations to prevent completely self-prescription of antibiotics and also other prescriptions only medicines in across many African settings, please.
Indeed, I think helped in Namibia by its small size. So I think, and then quite close, if you look at the University of Namibia, where we had our 3rd and 4th Muri meetings, there's really quite close time between the Ministry of Health and the pharmacy department in University of Namibia. I think that helps there. With a good education for the pharmacists, basically, so that they come out of there knowing that really antibiotics are no good for viral infections. So I think that part of that, so that when patients do come, they can say, well, look, you don't necessarily need an antibiotic. What about this? The other driving force what helped in Namibia was that prescription-only medicines are free of charge. So that also helps. So that if the doctor prescribes an antibiotic, they don't have to pay for it. So I think that's a driver there. In Kenya, what we saw amongst community pharmacists that have trained pharmacists is, again, they can help to explain to the patient what is the situation. So they don't need an antibiotic. This will be just as effective. We saw that in Republic of Srpska, which is part of Bosnia and Herzegovina, which is probably one of the poorest Central and Eastern European countries. Again, what they did was to train the pharmacists, provide guidelines for the pharmacists, things like that, along with finding them. So maybe that also helped as well, so that you can say to the pharmacists that we need, if you start to increase the number of inspectorates, and say to them, look, if they continue to do this, then we take away their license, or we fine them several $100s or things like that. All that can help going forward. Along with saying, well, look, starting in pharmacy school, look, it's no point giving an antibiotic for somebody with a cough or cold or whatever. It's just a waste of time. If you want to help them, you've got to treat them. You've got to help sort of get rid of their temperature by paracetamol, things like that. Symptom relief, really, rather than antibiotics. I think all of that combined can help to lower the use of antibiotics. As I say, we've seen that. I think there's been a recent paper in Sri Lanka that I'll send over to you, apart from those that I mentioned, where again they found that in pharmacies where they had trained pharmacists, there was less dispensing antibiotics without a prescription. So I think that's the key to me, and this is where community pharmacists can demonstrate their knowledge, really. Why go to pharmacy school for 5 years where all you're going to do is dispense an antibiotic to somebody with a cold? It just makes no sense to me. Because you're doing it then for commercial gain. You're not doing it for any patient care point of view. In fact, you're going to make it worse for the patient in the long run, because all you're going to do is increase your antimicrobial resistance rates.
Okay, thanks to that, Brian. I have a similar question from Bora Makuta, and she's saying, thank you for the great presentation. In relation to the success story of Namibia in regard of purchasing antibiotics, I would like to know if there are any other countries where you conducted research about the compliance to a standard treatment guideline by prescribers.
Well, standard, yeah. So we got Ghana. So you saw that there, where in fact there was quite poor adherence. Namibia was better. So Ghana was quite poor in ambulatory care, better in hospital care. We saw some issues, and I'll send you over Zimbabwe as well. So Zimbabwe is quite poor in hospitals. Ghana's quite poor in hospital, variable in South Africa. So I think what this shows to me is just generally across most countries, we're not that adherent to standard treatment guidelines. So we need to work, and the same with the SSI paper that I'll send over to you. So the first thing is to say is, okay, what are the treatment guidelines? What are the current prescribing patterns? Use those to develop quality improvement programs, put that into place, and then monitor adherence. And what you can do is sort of particularly education of physicians. You can put in quality targets, which are agreed with all stakeholders, and use that going forward. So I think, to me, that's a great role for hospital pharmacists going forward.
Okay. I have a question on pharmacovigilance from Mary Goretia team, asking that pharmacovigilance is one of the areas that's lagging in most of African countries. What is take on this, and how do you think it can be improved?
Thanks for that. I know the WHO is now putting, I think there's an African Union now talking about a pharmacovigilance, or almost like task force. I think under the WHO and others, we do see African countries coming together to look more at pharmacovigilance. I think within hospitals, look at that, which I sent to you, the South African study, because that looked at an intervention in hospitals that's easy to do. So have a look at that when you see that, because I think that can be done. I think with communities, it's more longer term. So I think looking when almost like the government's encouraging patients to talk to the pharmacists or to communicate. I think in Ghana now they can have a direct access to the Ministry of Health to let them know any adverse drug reactions. So I think you've got things like that in place, which we have in our Ghana paper. But have a look at the South African papers, what can be done within hospitals to improve the reporting adverse drug reactions.
Okay, thanks. I saw again a hand from Barbara Katusime. Barbara, welcome, as we are going towards the end now.
Yeah, I was going to say, to add to that, thank you, Goresi, for that question. And I think in Uganda, we've conducted studies on ADR reporting and found that healthcare professionals may not fully report their, for various reasons. And of course, the systems as well may be challenging. I think empowering patients to actually identify those reactions and report them directly, providing those platforms might also help, like Brian has mentioned. So I think that's something that we are looking to do for our research study. Yeah, thank you. Just to add on that. Thank you, Brian. Yeah,
thanks, Barbara. I agree with that. I think what we found in South Africa in our first paper was that quite often the doctors don't know where to report. So they see an adverse reaction, they don't know where to report. Also, they report them and they get no feedback. So they think, well, why do we bother? So I think those issues as well are important. Know where to report, getting feedback, things like that, all add to enhancing the rate of ADR reporting.
Okay.
Certainly, thank you. Yeah.
Thanks. So I think we have exhausted the questions, and thank you very much, Brian, for nice responses from your side as well. And also thank you very much for making time to attend to our today's presentation. And it has been wonderful to have you. And we hope that you will accept our future invitation to come on other matters on a similar topic about pharmacy profession in Africa. I know you have a lot of findings you would like to share, and please also you can give us a call or a hint that you want to talk, and we'll be happy to offer you another opportunity to minister to this symposium. And yes, maybe I welcome you, Brian, if you have any other concluding remarks before we close out today's session, please.
Well, thanks very much for inviting me. I'll just encourage you all. I mean, I was a novice to Africa until I got involved in 2015. And what's highlighted to me, and I know this is being involved in ISPI generally without ISPI Africa, is that there's lots of misconceptions. Firstly, as I said earlier about pharmacogenetics. So if you look at HIV, then very much a different profile in Africa compared to other countries. And the same with people with joint infectious and non-infectious diseases. So I think that's why we need more studies coming out of Africa. The other thing, and I'll send you over our COVID-19 paper, which I know is available on the internet. In it, a year or two ago, when the COVID-19 first hit Africa, we documented across Africa what was happening. And in there, we showed that there's quite a lot of innovation going on. I think the other misconception is that there's no innovation in Africa. So not only there's misconceptions about the sort of diseases and the prevalence of diseases and some of the management of diseases, but also misconception that there's no innovation going on in Africa. So I think both of those, yes. And that's why we need more studies going forward so that we improve the situation in Africa, that we make sure that when vaccines are available, that they're used, we lobby our governments or donors to make sure that they're free of charge. I think in South Africa, I think for the influenza vaccine, that the care workers have got to pay for it. Well, to me, that shouldn't happen. I think we should, as far as possible, make sure all vaccines are available all the time, readily available. Pharmacists have a role in that and utilize. I think the more papers we get out saying what are the key disease areas, what we can do about it, like the national action plans, what's in those for infectious diseases, how we can move forward, then I think the better. So that's why I'd encourage you all to research. I only started working research in Africa in 2015. So if I can do it as a 60-year-old, then you can all do it as 20, 30, 40-year-olds. So get involved and help research and push forward the appropriate management of medicines across Africa, because we need it, because we have as I said earlier, we have the highest rate of both infectious and non-infectious disease in Africa. So we need to make sure that our patients are treated as well as possible.
Okay. Many thanks, Brian, for those inspiring words as well to the younger generation. And with that, I would like to thank you all participants of today for taking your time to attend today's presentation. Looking forward to being with you in our next month's symposium, and we will keep you notified. Please remember to follow us on our social media platform. Pharmacy Forum East Africa is our tag. And we also like to thank our supporters or sponsors. We are supported by the Christian Social Services Commission of Tanzania, as well as the Action Media. And with that, I would like to call it a day. I wish you all.
Sorry, we got one Hassan down the bottom.
What? Please, can you?
Oh, somebody put up their hand. They've withdrawn it.
Okay. And we will send all the materials and presentation from Brian as soon as we can. So they will surely come into your email account, the one you use to register for this symposium. And I hope they will be helpful in your endeavors to enrich your knowledge on this matter as well. So thank you very much and see you next time.
Great. Thanks very much for inviting me.
Thanks.
Bye for now. Bye.
Bye now.
Thank you.
Bye.